we'll start. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 14E, which is Hematology, General and Fundamental. And we have a very important topic and a very special person to speak on the topic. The topic is very well known to everyone, the ABC of CBC. And to talk on that, we have the master himself here. Thanks to Dr. Anita Tailan, Dr. P Lokwani, he is here with us, the master of CBC and ABC of CBC. Dr. P Lokwani is an MBBS and MD from DAVV Indore, special training in hematology from PGI Chandigarh and Children Memorial Chicago, USA. Founder, Vice-Chancellor, ex-office, Madhya Pradesh Medical Science University, Jabalpur. Professor and head ex-chair, Department of Pathology, N.S.C.B Medical College, Jabalpur, MP. Member, Institute Body of AIIMS, ex-chair, Bhopal, MP. Member, HR Selection Committee, ex-chair, AIIMS, Bhopal, MP. Visiting Professor, Louisiana State University, USA. Consultant in charge, Department of Lab Medicine, Jabalpur Hospital and Research Center, Jabalpur. Ex-Dean Academics, Diplomat, National Board, Postgraduate Courses, Jabalpur Hospital and Research Center, MP. Chairman, Many Peers Team of National Assessment and Accreditation Council, NAC. Honorary Director, Sukh Sagar Medical College and Hospital, Jabalpur. With teaching experience of 38 years, 20 years in MGM and 18 years in N.S.C.B. Sir has had various orations, the famous of which it is the SEHPL oration New Delhi on 2016, multiple convocation addresses addressing the convocation ceremony of Maharashtra University of Health, MS Vaidhi University Institute of Medical Science, Bangalore, Indira Gandhi National Open University Convocation, Jabalpur, Minimal Invasive Surgeons of India Fellowship Convocation, Indore, keynote speakers in AIM for Seva, Canadian Chapter, Toronto, Canada, MCI Platinum Jubilee Celebration, Satya Sen Foundation, Jabalpur, World Sindhi Sammelan, Toronto in 2016. He's got various multiple books published by him, the famous of which, on which is the name of this topic, the ABC of CBC, a diagnostic interpretation of histograms in hematology, published by J.P. Brothers, and was released by the hands of Her Excellency, the President of India, Srimati Pratibha Devi Singh Patil at the Rashtrapati Bhavan. Various other books are Arts and Commerce of Hospital Management, Instant Solution to Hospital Problems, editors of about 25 magazines. Awards and felicitations, awarded the Charak Award in 2019, Padma Bhushan, Dr. S.K. Mukherjee, Chikitsa Seva Award, Distinguished Service Awards 2015 by the National IMA, Certificate Indian Dental Achievers Award, Certificate of Honor from King George Medical University, Lucknow in 2012, Certificate from Madhya Pradesh Hindu Bhavan Trust for Achievements in the Field of Education, Civic Facilitation Nagrik Abhinandan by the citizens of Kareli and students of various schools at MP, many research papers and dissertations and presentations, many workshops and conferences organized. We can go on and on. Before I ask Sir to start, let me request everybody here, please keep your mic muted, please keep your camera off, and at no point please do not share your screen. With this, I would not delay and would ask Sir to please present your screen, Sir, and let us start. We are all waiting for you. We are live on YouTube, sir, as well.
Good evening, one and all. I hope, Dr. Nadeem, I'm audible.
So you're clearly audible, you just have to make full screen, so your screen is not full.
Okay. Yeah, is it okay?
Sir, absolutely fine, sir. Just press that hide thing so that that pop-up goes away. There's a hide thing in the center. Just click on that. Perfectly fine, sir. Oh, it's gone. So you have to go back to your screen. It has gone away.
Yeah.
Absolutely fine, sir. Please start.
Good evening, one and all, and good evening, Dr. Nadeem, and all the distinguished people who have joined. It's a great pleasure and honor to deliver this lecture on this particular platform. And at the outset, I'm grateful to the organizers and in particular Dr. Anita Talian and Dr. Nadeem for giving me this opportunity and conducting this lecture series for the students and postgraduates and the consultants. I really salute your hard work and your commitment to the cause. With this, we start the subject of today, the CBC. CBC, the complete blood count, is one of the most frequently ordered and routinely done investigation, and I think it is the most common in the diagnostic laboratories. It's a Pandora box of information which aid in the diagnosis of multitude of diseases and disorders of human body. The simple investigation is economical, time-honoring, minimally invasive, available even at the remote laboratories, and yet exorbitantly informative. Well, with this subject, I would like to add one more thing. In the era of very sophisticated investigations, very sophisticated and dynamic medicine, going back to the very basic subject of CBC, there must be something. Let me tell you, with the changing dynamics of the technology, the last few decades have brought forth a radical change in hematology. The wheels of hematology have moved from predominantly manual practices. We remember nearby chamber and those hemoglobin estimation, small Xylese tubes, to the highly advanced automation. Particularly, the Coulter principle in the Coulter counter was the landmark in 1953 in the field of hematology. The prolific Coulter revolutionized laboratory medicine and laboratory procedure, changed the face of medicine by turning hematology guesswork, I'll say guesswork, into the accuracy. This is really a turning point, and for which we should appreciate the automation. What is needed for the novice practitioner is a way to approach interpreting the visual data and the numerical data got available from these automated cell counters. Unfortunately, I'm sorry to say, the skill is neither practiced in the university nor in the medical colleges, nor much books are available at the shelf of medical libraries. So the subject of CBC in this era of automation is not truly addressed properly. In such situation, the lecture series which has come up like this is a kind of a bridge which fills the gap between the classroom and the medical practice and the clinical practice. Automation principles in hematology, along with the interpretation of various novel parameters like RDW, SDW, IRF, IPF, LUC, etc., and graphical presentation in the form of histograms, cytograms, scatter plots have really changed the scenario, and all these things, they are encrypted with a lot of information and diagnostic information which can be used for the welfare of the patient and the better treatment and monitoring of the treatment. A long journey has been traveled from a single investigation era of hematocrit and hemoglobin to the most sophisticated multi-part, multi-para automation. With this brief introduction of the subject, I am proceeding with my subject of ABC of CBC. Just from where I got the experience, I salute my institutions of Jabalpur Hospital and Research Center, N.S.C.B Medical College Jabalpur, MGM Medical College Indore, and now at present I am with the SS Medical College Hospital, Jabalpur. What is CBC? CBC is the most frequently advised investigation. And what is CBC? A complete blood count, a series of tests for the measurement of hemoglobin, RBC and its indices, WBC and differentials, platelet counts, platelet volume, platelet indices, histograms, cytograms, and reports. I said we perform it very frequently. What is the utility of performing this basic hematology test so frequently? Just one sec. I think for some reason the other thing is picked up. Wrong is picked up. Just 1 second. I would like to have one minute.
No issues, sir. No issues.
So there is some problem. I think I picked up a wrong. Yes, that's right. Yes, that's right. That's right. This one is right. Then coming to the what is CBC. Now this kind of a graphs and other kind of a graphs are very frequent nowadays from the 3-part to 7-part, 6-part cell counters. So CBC is a complete series of a test including RBCs, WBCs, platelets and all those things we know very well. Is a most frequently advised and ordered investigation. You will agree with me whether the patient is in the IPD or is admitted or in the OPD and coming, irrespective of what the problem he has and what kind of a disease he is suffering from or what are the complaints. Our first investigation in the list of investigation ordered is no doubt the CBC. Now, we advise it. Why we advise it? We'll discuss. But it is very sure that almost to every patient this particular report is there. And going for this lecture is that this report, which has lot of encrypted information for the patient's benefit and the clinician's benefit, we are not really utilizing very beneficial parameters, and we are going to discuss in the slides to come. What is the utility of performing CBC so frequently? Half of our population suffers from different type of anemia, nutritional, hemolytic, aplastic, sickle cell, thalassemia. Infectious diseases, we know it has acquired almost epidemic proportions. Bacterial, viral, dengue fever, parasitic, malaria, then now this COVID, leukocytosis, leukopenia, eosinophilia, necrocytosis, and so many things. They are there right and left. And now the thrombocytosis and thrombopenias of various origin, primary and secondary, the ITP and TTP and DIC, and the thrombocytopenias because of the dengue fever and other problems. Apart from that, diagnosis of anemia and the variety of anemias to be differentiated, hemoglobinopathies of thalassemia and sickle, hemolytic anemia, various parasitemia, thrombocytopenias, again I am not repeating in viral and bacterial infections, various hemopathic malignancies, leukemia, dysplasias like MBBS and other syndromes, and the effect of various drugs, particularly chemotherapy and radiation therapy, and to diagnose effects of various types of stresses like metabolic stresses, traumatic and neoplastic and surgical stresses. Well, this was the exhaustive list why we do the CBC, but at the same time, this is the most important screen. On top of everything, with modern automation and its extensive menu, friends, the preliminary diagnostic information, directly or indirectly, this single test of CBC can generate and make available to the pathologist, to the clinician as a guide for proceeding further towards the right direction of final diagnosis is truly unique. I'll say that's why we order this test, but unfortunately we don't utilize it to its maximum. Basic CBC includes, for years and ages, are these parameters we all know: hemoglobin, RBC, platelet, WBC, and the indices of basic nature: MCH, MCV, MCSC, MPV. With the scope of the lecture of the today and time restriction, I am not going into the details of this. Practically everybody who is right now joined us knows about it a lot. I will not repeat anything. Now, there are histograms, scatter plots, and cytogram, RDW and SD. These things have been introduced. But more than that, if you see the most sophisticated automated counters, they generate more than 35 plus parameters of CBC. Some are observed and some are calculated. There's a huge and exhaustive list of RBC and WBC and platelet parameters. Again, I'm not going to enumerate, but be sure some of these parameters, which are novel parameters and newer parameters, we are definitely going to discuss in the slides to come. Histogram, cytogram, and scatogram also. Now, automation, various companies, various manufacturers, various brands. Each analyzer has its own personality. Now, this is one thing where I would like to remember a person. Just a couple of weeks back, there was a 2-day workshop organized by Cube, and the great person who is who is an authority, another authority, Dr. Anil Handu from Delhi. He was delivering a lecture what he needs from the CBC and what he needs from the manufacturers of cell counters. I will quote his word that I need uniformity of the generated documentation date, investigations in the parameters, so that we can have a common kind of understanding of the subject. Yes, this is one point which is creating problem, that we are not able to design anything and document anything and write on the text anything which should go uniformly to everywhere. No doubt this competition of the cell counters, they are producing novel, good and better and best parameters and newer parameters. But I think if they are uniform, they will work better for the telling humanity. Each analyzer has its own personality and each analyzer has its own technology. Again, I will not go into the details of the technology, but at the same time, impedance, absorbance, spectrophotometry, optical technology, fluorescent technology, conductivity, cytochemical staining, monoclonal antibodies, and variable combination of these technologies. Then, of course, the technologies which are incorporating the flow cytometry and peroxide basocytometry and use of peroxide baso for the generation of the results. They have really changed the scenario. And there is another thing which has been added is option for the automated rating count. So I'll not go into the details of these technologies. I'll simply move from here that there are best of the combinations given to us in the sophisticated cell counters. Now with this background, I will move, because in one single lecture we can't just go through all parameters of CBC, which include RBC, WBC and platelet parameters. We start today with the RBC related parameters. This is the list of RBC related parameters. Half of it we all know, I will not repeat. Half of it, they are newer. I'll have few slides just to enumerate their use and their significance in various conditions, and then we'll move to the subject of interpretation of histogram and cytogram. Again, this particular lecture is for students, is for pathologists, and also it is for the clinicians. I know many of my clinician friends have also joined. So I will say, just keep patience, few more slides which may not interest you, and they are to the pathology mode. We will come to the clinical aspect of it. Today we will be discussing RBC related newer parameters, which will include red cell distribution with RDW are very, very important. I'll say the most important parameter which has come up in last 2 decades. Reticulocyte in again IRF, immature reticulocyte fraction, reticulocyte hemoglobin, the macrocytic to hypochromic ratio. Nucleated RBC, of course, I'll not go into detail, we all know about it. Fragmented RBC. Why we have included nucleated RBC and fragmented RBC and MH ratio here? We used to do earlier also. But because now with the sophisticated cell counters, they are generating it on the automation. So the subjective error has been eliminated. That's why I have included. And of course, at the end, we'll have some case presentations and RBC disorders with RBC histogram and RBC cytogram interpretation. So we come to the red cell distribution width. I say this has changed a lot in hematology. Red cell distribution width is a quantitative measure of numerical expression of anisocytosis. We knew anisocytosis by poikilocyte. Anisocytosis is a variation in the cell size, and RDW is a degree of variation in the red cell size, what we call heterogeneity of the cells. A very, very important. Now, why it is important? I'll tell you. The cell excessively heterogeneous. See, ultimately the job of the RBC is to carry the oxygen and release it to the tissue. Cell excessively heterogeneous in size would not present in a reliable amount of oxygen diffusion surface to the capillary endothelium. I would like that the students should concentrate on this particular slide. If you see this diagram, here you will find that there is anisocytosis. Lot many RBCs have the different sizes, so lot of heterogeneity is there. So cells excessively heterogeneous in size would not present a reliable amount of oxygen diffusion surface to the capillary endothelium. On the other hand, if they are rigid, the red cell size is controlled, a large number of cells would be quickly destroyed by the spleen. So they cannot be rigid. So what is a balance? The balance is acceptable heterogeneity. The heterogeneity of red cell property, therefore, under physiological condition, I will repeat again, under physiological conditions, is a result of balance of acceptable function versus the cost of quality control. See, this is a histogram. We'll discuss later. This is a normal histogram. And this normal histogram has an acceptable RDW, acceptable heterogeneity, acceptable variation of the cell size which is needed so that they are not killed by in the spleen, and it is not too high or too low. High heterogeneity, particularly that is increased RDW, is therefore non-physiological. It is pathological. And we are going to discuss these conditions in detail in the histograms and cytograms in the slides to come. And here what is why it is important and why we should go for it. Now, we all are aware nowadays almost it's very common to have cell counters. So RDWCV is calculated by SD upon mean corpus volume and 100 into 100 and normally ranges from 11.5 to 14.5. Whereas the ST is the width of the histogram and measured from the histogram is drawing an arbitrary line at the 20% height on the y-axis, and this is normal ranges about 35 to 45 femtoliter. You can see here this is an isocytosis of cells are of various sizes in the same population. One single slide on the hemoglobin distribution width, that is SDW, it goes again almost with the RDW. SDW is measurement of anisochromia, that is hemoglobin concentration, whereas RDW was a measurement of anisocytosis. But it is similar to that, anisochromia and the hemoglobin concentration. SDW normal is 22 to 32 gram per liter. SDW differentiates between the causes of microcytosis, macrocytosis, and is only available on the analyzers which work on the principle of optical red cell technology. So there are very few which are delivering or generating this particular parameter. Very important. See, the microcytosis caused by iron deficiency anemia will have raised HDW just like will have raised RDW. The thalassemia trait on the other hand has normal HDW just like normal RDW. Macrocytosis in various conditions, if we go, alcoholic liver disease will have low HDW, megaloblastic anemia will have either normal are borderline raised HDW and hemolytic anemia will have very high HDW. HDW values differentiate causes of microcytosis and macrocytosis, and different cytograms along with that will give the diagnostic help in various conditions. Now, with this background, I am coming to another very important slide, and that is anemia classification. We all know anemia classification based on the morphology, normocytic, normochromic, microcytic, hypochromic, macrocytic. We all know anemia classification basis on the etiology, etiopathology, nutritional anemias, aplastic anemias, and bone marrow suppression, and hypoplastic anemia, and anemias because of the leg poisoning, and anemias because of the B12 and maturation problems of folic acid and iron, and so many other situations, and the hemoglobinopathies, and the sickle cell and thalassemias, and other situations. Those all established classifications are there. But to reach those diagnoses, they need sophisticated investigation. We may need iron studies, we may need vitamin studies, we may need some kind of a bone marrow studies, or we may need some kind of A2 estimations and other things, which are expensive, which are not easily available to our population. But think about it. If a basic common anemias can be classified on the basis of the CBC report, the paper, the printout of which is already available on the desk of a clinician, and the patient has paid for it, and it is not expensive, it is available easily. Suppose from the data, the graphics which are available on that are properly understood and interpreted, and we can just classify these anemia, how good it is. I come to that. If we can divide and decide about anemia's basic, at least, guideline on the basis of only N.S.C.B and RDW, how easy it. Now, I have N.S.C.B and RDW. N.S.C.B can be low, it can be normal, it can be high. So there are three possibilities. Whereas RDW can be either normal or high. Again, let me tell you, low RDW is theoretical, practically it is not there. So we have only two possibilities. Now 2 into 3, we have 6 permutation combinations with these two things. And with these 6 permutation combinations, which are available in the CBC report, we go to classify it. I, at this point, will remember a great man, Dr. Bestman, who in late 80s and 90s did a lot of work on these histograms to understand when there was no data available. So he helped to classify in this manner. I have compiled it and I am presenting it. Again, I am telling you, it is not an absolute phenomena, but it can definitely reduce the spectrum of differential diagnosis, so we can be guided to the final diagnosis. Just look at this. I would like the students to concentrate on this. Now, we have a normal RDW, so no heterogeneity. We have a high RDW, so heterogeneity. Just for a moment, forget low RDW, it is not there. For a minute, forget it. So, we have two parameters, RDW high and RDW normal, heterogeneous or non-heterogeneous. Here, on this thing, we have M.C.B which is normal, normocytic, M.C.B which is high, macrocytic, and M.C.B which is low, microcytic. Now, with the normal RDW, normal M.C.B, what are the possibilities? Number one is a normal variant. Then, anemia of chronic disease, acute blood loss, hypothyroidism, anemia of renal, chronic lymphocytic leukemia in some cases, and CML in some cases of hemoglobinopathy, not absolute, again I am telling you. If we move from normal RDW with a M.C.B high macrocytic, so aplastic anemia, pre-leukemia, myelodysplastic syndrome of some cases. If we go with the RDW normal and M.C.B low, anemia of chronic disease, thalassemia heterozygous. We know about it. Now again, I repeat, we have covered three things: RDW normal with normocytic, RDW normal with macrocytic, RDW normal with the microcytic. I will say just go through the possibilities and keep in mind this is a mathematics totally. I move to RDW high, heterozygous. RDW is one thing out of RDW and MCV which is changing or increasing, because it can't decrease. Changing, it means increasing much before MCV. And this is the trick. RDW is increased much before MCV. So what happens? Anemia, if we classify high RDW with a normocytic or normal MCV, early iron deficiency anemia. We are going to discuss. I tell you, if RDW is only high and MCV is very much within normal limit, and even the hemoglobin is 14 grams, where you can't call it anemia even, you can think about that the patient is entering into iron deficiency or megaloblastic anemia. Because RDW goes high much before MCV. Again, remember this point. So RDW high, MCV normal is possible in early iron deficiency, early vitamin B12 deficiency, and early folate deficiency, and some of the hemoglobinopathies in sickle. RDW high with the macrocytosis is vitamin B12 deficiency, we all know. Folate deficiency, we all know. Immune hemolytic anemia, no. Liver disease, yes, we know. Cold agglutinations, alcoholism. We know this battery where RDW is high and MCV is known high. We move to the low MCV with the high RDW. Again, heterogeneity with microcytosis. We know very well iron deficiency anemia. Fragmentations of RBC, HBS disease, thalassemia intermedia, and G6PD deficiency. I think if on the desk of a clinician he just going through a single investigation of CBC, and if he can help the patient or poor patient not to go for the very expensive investigation, and if he can just pinpoint the diagnosis, not in all cases, but at least he can reduce the battery of expensive investigations and he can try it, I think nothing wrong in that. So from here I come to the low RDW is not observed normally, but theoretically it is possible only the marrow level. Sometimes some people say that low RDW, low MCV in thalassemia and high RDW, high MCV in the aplastic anemia, but it is practically a theoretical aspect. Practically you should forget about the low RDW. Now, can I size it? What we have seen in the last slide? Very easy. All hypoproliferative disorders, independent of MCV, have normal heterogeneity, so normal RDW. Again, all hypoproliferative disorders, independent of MCV, whether microcytic or macrocytic, have normal heterogeneity, so normal RDW. Examples are thal minor in microcytosis and aplastic anemia in macrocytosis. All nutritional disorders, independent of MCV, have increased heterogeneity. Micro or macro, all nutritional disorders have increased heterogeneity and increased RDW. I would like to quote in micro, iron deficiency anemia, and macro, vitamin deficiency, megaloblastic anemia. Coming to the third group of disorder, all hemolytic disorders, independent of MCV, have heterogeneity, that is increased, and the increase is directly proportionate to the degree of anemia caused by that particular disorder. So here also RDW will increase. I mean, this is a very easy way. If it is at the marrow level, no RDW, no heterogeneity. If it is at the nutritional or maturation level, high RDW, high heterogeneity, irrespective of MCV, micro or macro. Hemolytic, high RDW, high heterogeneity. It is but natural because the cells will be of different sizes because of the hemolysis. So I think this is a gross summary of the last classification. We move to reticulocyte. Here I will go fast because the time is limited and lot of material is there. So please bear with me. I will not go into the detail. What is reticulocyte? Practically everybody knows it's a cell short to mature cell, and it's in the journey of erythropoiesis. The ribosomal RNA can be strained with the methylene blue and plain casyl blue supravital strains. Number of increased marrow, Then reticulocyte number increases when the marrow is churning out the RBCs at excessive speed because of the peripheral challenge, presumably to make up for those lost to hemolysis or hemorrhage the RBCs. Lifespan is 120 days, and 0.8% of the red cells are to be replaced daily. And this is what we see under the microscope. Again, a very small thing, the corrected reticulocyte count or reticulocyte index. This is nothing but the reticulocyte into the patient's hematocrit, upon normal hematocrit. This is the correction factor. Suppose the observed reticulocyte count is 6% and hematocrit is 15, then the index will be 6 upon 15 upon 40 into 15 upon 45. That is 2 will be the actual reticulocyte count. I move. Maturation of reticulocyte, the newer fluorescent flow cytometer techniques now allow us to categorize the reticulocyte based on their degree of maturation. This is done by measuring the RNA content of the reticulocyte as fluorescent intensity. The higher the RNA content, the less is the mature the cells are, and low fluorescence reticulocyte mature, medium fluorescence, medium maturity, high fluorescence. These are the 3, 1, 2, 3. 2 is the low absorption, 3 medium, and low 4 is the high absorption. Now we go to another important slide, and that is the immature reticulocyte fraction. Now all the cell counters are not giving this particular parameter. There are list of the parameter instruments are there, maybe more also, which are giving this particular important parameter. What is this? Immature reticulocyte fraction is a marker to show the effectiveness of erythropoiesis in a patient. IRF is calculate ratio of newly released reticulocyte to the total reticulocyte. Very sensitive marrow of the erythropoietic, measure of the erythropoietic activity. Particularly in patients of marrow transplant, the evaluation is very nicely done with this parameter. And also it is useful to see the response to the EPO therapy. Now, immature reticulocyte fraction evaluation of the combination of IRF with the retic count may be used to diagnose and decide the etiology of anemia in some situations. Some examples are low IRF with the low retic. This will suggest naturally the aplastic anemia and renal failure because the erythropoiesis is hypoplastic. High IRF and high retic count would suggest hemolytic anemia or blood loss. It is opposite of the first one. High RF with a normal to low retic would suggest folate and B12 deficiency and iron deficiency in the maturation problem. Normal IRF with the low and normal retic would suggest anemia of chronic disease. This is a combination. Now, in an option where the retic count is possible, we get retic count, we get IRF, and these parameters are with us, and we can simply with that report only, we can proceed with some kind of guidelines for the diagnosis. Again, I am oversimplifying this count. It's a valuable count in cases of anemia. If the disease causing anemia is inside the marrow, the reticulocyte count is decreased or low or none. If the disease causing anemia is outside the marrow, the reticulocyte count increases. This is just to remember. Now this is another thing, reticulocyte hemoglobin equivalent, rat hemoglobin. Again, few parameters like Sysmex they generate. Rat hemoglobin is a measure of iron availability in the bone marrow and may serve as a screen for iron deficiency with or without anemia, above and beyond the traditional biomarkers like iron, ferritin, PIBC and percentage saturation. Screening of infants for iron deficiency, evaluation of iron deficiency in end-stage renal disorders and disease and chronic dialysis patient is very helpful in other chronic diseases associated with inflammation in which traditional biomarkers are misleading. Rat hemoglobin is taken as essentiality equivalent to CHR, that is reticulocyte hemoglobin content. Now, listen, rat hemoglobin and CHR, they are not exactly same but go similarly. Rat hemoglobin is a Sysmex generation and CHR is a Siemens generation in a different kind of manufacturers. While not identical, these parameters essentially measure the same thing in the reticulocyte. The microcyte to hypochromic ratio help to distinguish thalassemias from iron deficiency. We know it even otherwise. Thalassemia shows more prominent microcytosis than hypochromia, and IDA shows more hypochromia than microcytosis. So NH ratio, M to H ratio. If M is more, H is less, then it will be more than 1. If M is low and H is more, like an IDA, so it will be less than 1. So this can differentiate grossly, not absolutely. Nucleated red cell, again I will not go into the detail. We know various conditions where we come across erythroblasts. They are always pathological unless they are from the neonatal blood sample. Anywhere otherwise it is some disease process they indicate to. And regarded as reflection of extreme increase in the erythropoietic activity. These are the various stages of normoblast. And one thing important, why I have mentioned it, with the automation and the newer cell counters, nucleated red cell found in a signature position on an impedance size white blood cell count histogram. When we discuss MBBSs, we will discuss these things, but they have a signature position, like here is the NRBC. They have the signature position in Parox and Baso scatter plots also. Fragmented red cells, I think I'll discuss when I'll be discussing the histograms. But schistocytes are fragments, what are also labeled as helmet cells. They are very important. We can see on the smear, on the peripheral smear under the microscope, but again, the errors and imprecision is always there. So they are very useful. These are the helmet cells you can visualize here. They have both side point and they have good hemoglobinization. Diagnosis of microangiopathies are extremely important as they are life-threatening diseases. The identification of quantification of fragmented red cells is important in diagnostic criteria. Manual microscopic evaluation of fragmented red cell is both imprecise and subjective. So automation has definitely given eye into this. Now the reasons for fragmented RBCs again are the valvular synthetic valves and the various heart conditions, synthetic heart valves, endocarditis, aortic aneurysm, and various types of microangiopathies including HUS, RTTP, disseminated carcinomas, DIC, cytotoxic chemotherapy, and immune disorders and infections, and transplant-associated thrombotic microangiopathy, various conditions where we come across these fragmented red cells. We'll again discuss when we'll discuss the histograms. I am coming to the subject of RBC histogram and cytograms. Now here, one second. This subject is very close to my heart, and I'll tell you why. In one of the histogram when it will come in this series, I'll tell you the small story of mine, how I started understanding the CBC and particularly histograms and now scatter and cytograms. What was the cause and what was the drive behind it and how I started with that, I'll tell you that. But let me tell you, they are the graphs which are encrypted with lot of informations. Probably in course of time we'll learn more. But even now, we can draw so many things out of it and we can help in the diagnosis and treatment monitoring. Why this discussion? Because RBC, histograms, cytograms, poor cousin, most advanced on the WBC differential newer RBC numerical parameters and flag graphical output is largely ignored. Yes, we are ignoring, we don't really see them. We go to the numerical values only. Contains valuable information. The most important point is some plots are virtually diagnostic and they tell something which PS can't tell us, or the traditional things are manual things, we cannot draw those things. Pattern recognition is the key of that. Sorry. The advantages are they can guide the physician on hematological status, clinical decision making is comparatively faster, and relevant tests can be ordered early, and more important is unsuspected condition may be picked up. So interpretation of these graphs along with RBC, hemoglobin, hematocrit and other parameters, numerical parameters will take us to the diagnosis. You know, this is a three-part differential cell counters report, and this is having these graphs which we call histograms, and these are the numerical values which we take care of, but we ignore them. We should not anymore. What is a histogram? Histogram is a not only in this hematology, it's a general parameter which is used at many places for comparing the two particular things. Now, if I go through this, histogram is a graphic representation of blood cells for our purpose and produced from thousands and millions of signals. You see, not many things which I told you, the technologies, impedance, another technology, and laser technology. Hydrodynamically, we make a single file of the cells which passes through that counter, and there is a hole from which impedance technology with the electric or the radio frequency or laser, it is deviated, and this deviation is recorded by the computer and artificial intelligence. And this way, the size and frequency of occurrence in the population is collected by the computer and notified. And this makes this particular type of bell-shaped curve. This is the maximum frequency or maximum occurrence of a cell here. On this is the size, and on this x-axis is the frequency of occurrence. Now when we make this standard deviation curve, then 68% of the cells, they fall in the 1 SD area, that is between this line and this line. 95% of the cell, they fall between this line to this line, that is 2 SD what we take in consideration, and 99.7% they definitely fall in 3 SD. So in this, if it goes with this frequency, then the curve is a Gaussian curve and a complete bell-shaped curve. But if there is a variation, then definitely there will be change in the curve, which we'll see in the subsequent graphs. Now, volume histogram reflects the size of the erythrocyte and any particle in that range. The instrument counts the cells in the range of 25 femtoliter to 250 femtoliter. So, and the RBC histogram is symmetrical and bell-shaped curve. Under some situation, there is a flagging if the curve is not bell-shaped. The area of peak is used to calculate N.S.C.B. This is a normal diagrammatic curve, normal histogram. We have seen earlier also. Now, if you fall from this peak to the center, like it is falling at 90, this is a N.S.C.B. mean. This side cells are microcytic or smaller, I will say. This side cells are bigger, but the average mean is here at 90. The peak at 60 to 125. The red cell distribution width is also calculated, I told you, at the 20% of this. Again, this is the RBC histogram between 25 to 250 here, and this is my bell-shaped curve. The floating area in the range of 60 to 125, there is a lower and upper discriminator from in between. This graph is formed, and the graph in a normal condition should touch the baseline. The cell size between these two is 25 to 250, and this falls between this range of 65 to 120. Flagging is there in case there is some change. If this graph shifts to left, it is microcytosis. If it shifts to right, it is macrocytosis. If it is widened, then RDW is more and heterogeneity is noticed. I'll go through a couple of slides to show you some changes or variations. There are some variations. The RBC are larger. I told you is macrocytic left. If right, right, it is macrocytic. If microcytic, then the shift is to the left. And there are changes because of the presence of erythrocytic fragments, leukocytic fragments, and large platelets. If the histogram curve is bimodal, camel hump, then there is possibility that two populations of red cells are there in single sample. It may be possible because of the blood transfusion, cold agglutinin, hemolytic anemia, and cystocytes anemia with different size of cell population, and after the treatment of certain kinds of anemias. Normally, WBCs are statistically insignificant to cause any change in RBC histogram. Sometimes we do come across when the leukocyte count is very high, 2 lakhs and 3 lakhs, like in CLL, there may be interference. We will see at one of the slides. Now, these are the flaggings. If this particular graph is not starting from the base and it is more than about 10% of this curve is considered that this is a lower discriminator flagging. It is because of either there are platelet clumps which are interfering, or RBC small fragment which are interfering, or the giant platelets are there, or some microerythrocytes are there. Similarly, if on this side, if it is not touching, there is a RBC agglutination possibility, NCLL. Again, RDW can be misleading if the chart is not complete. RBC microcytosis, we say if the microcytes are more with the volume less than 60 femtoliter, which can be seen, the graph is shifted from the lower discriminator to the left side. Where here it is shifted to right side from the upper discriminator. So this is macrocytosis. Anisocytosis is like this, that there are cells with the normocytes or maybe microcyte with the normocyte with the microcyte. So there will be high RDW, and if RDW is more than 50% variation, it is flagged in the cell counters, or there is a possibility when there is this kind of a camel hump, double or bimodal curve, which may be seen in various situations we have seen. Now, one interesting thing should be documented here. High RDW will not tell you whether the graph belongs to this or graph belongs to this, whether the heterogeneity of the cells is towards the macrocytosis or heterogeneity of the cell is towards the microcytosis. It will not tell you. It will just give you the numerical figure. Hypochromia, of course, when it is less than 28 gram per deciliter. Now I am coming to a very important point, a very important thing, which is a newer observation with the very sophisticated analyzers like ADVIA 120 and others. This is RBC cytogram. Sophisticated newer analyzers perform red cell analysis by flow cytometry and laser technology. The cells move through the laser beam analysis is done based on the degree of scatter. The red cell cytogram is graphical, represent two light scaters. One is a high angle 5 to 15 light scatter is plotted on the x-axis here, or say here, and low angle scatter 2 to 3 degree light scattering, which is on the y-axis. Now, if you see here, this is a high angle scatter which decides the density of hemoglobin, concentration of hemoglobin, and the refractive index, whereas low angle will see for the size and volume. So low angle is on the y-axis, that is size, and high angle, that is hemoglobin concentration, is on the x-axis. This is a very interesting cytogram study. Nowadays, this comes with your CBC report, and watching the variations of this are very interesting and will help you and give you confidence in the reporting. RBC cytogram represents volume versus hemoglobin concentration. Volume hemoglobin cytogram patterns are plotted in 9-part grid. I'll explain you how on the x and y axis. Hemoglobin concentration is plotted on the x-axis and cell volume on y-axis. X-axis hemoglobin concentration is between 28 gram deciliter to 41 gram deciliter. Red cell with hemoglobin concentration of less than 28 gram is hypochromic, and more than 41 gram is naturally hyperchromic. On y-axis, size is there between 60 femtoliter and 120 femtoliter. Anything less than 60 gram femtoliter will be microcytic, and more than 120 will be macrocytic. Most RBC plots fall in the central zone of normocytic. Now, here we go for microcytosis, macrocytosis, hypochromia and hyperchromia, these 4 parameters. Now, what happens? We have normochromia, hypochromia, hyperchromia. We have normocytic, hyperchromic, microcytic and macrocytic. So 3 in the volume and 3 in the hemoglobin concentration. 3 into 3 is 9. So 9 permutation combinations are possible when we see the plot of cytogram. Let us see. Normal red cells, because they are normocytic, normochromic, they fall in the central. Abnormal red cells move to their respective position. The specific is not absolute. See, the study of this is not absolute, but understanding of this cytogram, diversified cytograms with histogram and numerical parameters are going to help you a lot in the diagnosis and monitoring of the disease. Now we are going to the pictorial grid labeling 9 squares, how it goes. See, now just concentrate on this. These are 1, 2, 3, 4, 5, 6, 7, 8, 9 boxes. How they are made? They are divided on the x-axis by one line which is 28 gram per deciliter concentration, other line is 41 gram per liter concentration. Anything beyond this is hyperchromic. Anything beyond this side is hypochromic. Another two lines on the y-axis are 60 femtoliter and 120 femtoliter. Anything above is macrocyte and anything below is microcyte. So these horizontal lines, they decide the size. Normocytic, this line. Microcytic, this group of lines. Macrocytic, these three lines. Again, these two lines will decide hemoglobin concentration. I hope I am not going very fast because lots of slides are there. I am going slightly faster to cover the subject. But anyway, this slide I would like everybody to understand the cytogram. So these 9 boxes will decide two things: microcytosis, normocytosis and macrocytosis. Hypochromia, normochromia and hyperchromia. I am sure this must be clear. Anything below 60 femtoliter, whether this box or this box, all three boxes are microcytic. Anything in between 60 and 1T, whether this box or this box, they are normocytic. Anything between these three boxes above 120 femtoliter is macrocytic. Again, coming back, if we go to the x-axis, that is hemoglobin concentration. Anything in these three boxes which is less than 28 gram is hypochromic. Something between 28 to 41 in all three boxes is normochromic, and anything beyond 40 gram in all three boxes is hyperchromic. I think the things are clear. Now, most of the normal, which are normocytic and normochromic, will naturally fall here. So, this is the normal cytogram. I think this pictorial grid is, I'm sure must be clear to all of you. We move. What is the utility? Contains valuable information. Some plots are virtually diagnostic. This is the most important statement. Can guide physician treatment. Decision making is faster. Adds to monitoring in EPO therapy. Detects spherocytes. Unsuspected conditions may be diagnosed. Now we move to various cases and various conditions with this background of knowledge or whatever we have discussed in last 45 minutes was the various newer parameters. We discussed how the histograms are formed and what are the variation. We discussed how the cytogram is formed. With this background, we are moving to the disease-specific histograms and cytograms in next few 15-20 minutes. Now, this is a normal RBC histogram. If you see the smear, normocytic, normochromic. If you see the values, all values are normal with the RBC, hemoglobin, hematocrit, N.S.C.B and RDW, normal. And this is acceptable variation, and this is a normal histogram. Now, I tell you, in subsequent slides, though we do not get it in our reports of various histogram, various cell counters, maybe whatever sophistication is there, but we don't get for comparison of normal and abnormal histogram and cytogram. But here, for the understanding of the subjects and for the understanding of the students for the subject, I have created these pictorial histograms and cytograms. So this is a normal histogram, this is a peripheral smear, and these are the values. Now subsequent slides will contain all these things and will have the comparison. Again, if you go through this slide, RBCs are normocytic, normochromic. This histogram is normal, there is no variation. All these numerical values, they are all normal. This is a cytogram. This is falling in this box, so this is a normal cytogram. Majority of the cells are falling in this, which is normocytic, normochromic. We move. Now, if you go through these readings, RBC, hemoglobin, hematocrit, N.S.C.B, RDW, everything is normal. But for RDW, which is raised. This RDW raised is hello, am I audible?
Yes, sir, you are audible. Please go ahead.
Okay. So, if you go through all these numerical values, everything is normal. See, the hemoglobin is 14.2. You can't tell it is anemia. N.S.C.B is 87. You can't say it is microcytic or anything. But RDW is more. This is single alarm. And if you come to the histogram, this is the normal histogram, red one. And the black line one is a patient histogram. This is comparison. Again, I'll say no instrument generates this kind of a mixture of normal to abnormal or comparison. But this is for the understanding. What you notice, this histogram of the patient has moved to left. And there is a small population here, which is definitely microcytic. And since it is widened and heterogeneity because of the normocytic and few cells microcytic, there are enough cells to cause the shifting of this histogram, but not truly enough because of the lifespan of RBC to make a change in hemoglobin and N.S.C.B. I hope you understand. So this change is causing, because RDW is derived from the histogram, so RDW has changed. But still, there is no change in the hemoglobin and N.S.C.B in the hematocrit, which can say that we are entering into hemoglobin anemia. But just imagine, again, this is one thing for which we go for the histograms. Isn't it very interesting? A case of antenatal going to the obstetrician and brings this report. An obstetrician is well versed with the histograms and other findings. With the 14.20 hemoglobin, nobody will say anemia. But if she notices that there is something microcytic is coming, and this is, she is entering into the iron deficiency, and right at this juncture she supports it. Isn't it interesting and useful? So this parameter can be used in the clinical practice by the clinicians. I move. Again same. See, smear is totally normocytic now. Everything is normal except for the RDW here and this histogram here. And if you go through the cytogram, you just see that some of the cells, they are in the hypo, and some of the cells, they are in the micro region here. And this histogram has moved from normal to the hypo region to the microcytic region. Not, of course, enough amount of cells are there which can totally move this to hypo and micro region. We will go to that. And this is what is the early iron deficiency. If I move to this, now here, smear is very clear, microcytic hypochromic, RBCs. If you go through all these numerical values, I am sorry, may not be visible very well, but they are all depressed. Hemoglobin is just 7.3 and N.S.C.B is reduced to 62 and RDW has increased more to 18.20 and the histogram has moved to left to the microcytic zone. This is a clear-cut advanced deficiency. If I go to this slide, again, now it is clearly visible that all the parameters are going down, but the RDW is going up. The histogram has moved to left totally, and smear is showing this. And look at the cytogram. This is very typical wedge-shaped cytogram. Hypochromia is more, microcytosis is comparatively less compared to hypochromia. So the MH ratio is more than 1, and here MH ratio is less than 1. because microcytosis is less and HAH is more. So this is a clear wage. This is a typical of iron deficiency anemia in the cytogram, and this is generated. I'll show you all. Now this is a report coming from the most sophisticated equipment to the cell counter. Now look at this. These are the scatter plots we'll be discussing later when we'll be discussing the WBC. This is a platelet scatter we'll be discussing later. These are the RBC histograms, and this is a high RBC scatter, and this is a cytogram here. This is of course your retic. Now what all we are seeing, just look at it. MCV is 60. MCH is 14, 16.5. So they are low. Histogram has shifted to left. Right? Cytogram is clear showing hypochromic zone and microcytic zone in the wage. This is a true report. Those were the diagrams. They were made diagrammatically and planned to make you understand. But this is a report. This is how you get it. So this is a cytogram, and you can see this is macrocytosis, which is reported in this particular instrument is 3+, and hypochromia is reported 3+. Everything is reported. So this is a case of microcytic hypochromic RBCs. You can see on the smear also hypochromia. Moving, recovery from iron deficiency. We have seen iron deficiency. Now in recovery we find there is a mixture of the cells of normocytic and hypochromic also and microcytic also, and there are changes in the values, but still the values are lower, and the RDW has increased much more, 22.2. And if you look at the histogram, which is very, very important, there is again a hump here. It is not a true bell shape. This is one, and here it is going here and this way. So now this particular histogram is showing two populations, a population of iron deficiency microcytic and a population which is coming into the normocytic zone after the treatment. So this is a normocytic recovery of iron deficiency anemia, maybe with the hematinics and other things. So in a serial performing CBCs of an antenatal or any other patient who is suffering from iron deficiency, you can see, without going for the iron studies, without going for other studies, a clinician, an obstetrician can realize that whether his treatment is working or her treatment is working or not. How important, how interesting, without spending a single rupee extra. CBC, naturally on every visit you get it done. Now we go to the another. Now look at it, normocytic recovery here. Microcytic zone is still there. Two populations. Wide grams, so very high RDW. And look at this cytogram, very typical. If you can make out very well, there are two populations of cell. One wage is this, which is old microcytic hypochromic, and one wage is coming in the normal zone, which is a recovery RBCs in the normocytic normochromic zone. This combined, this is a kind of a two populations there. So this is a recovery from iron deficiency. I'm coming to the actual report, and here if you see what all we see here, see the two population on the cytogram. You can make out very distinctly. This is microcytic hypochromic and this one is the normocytic zone. There are two population in the scatter plot also. There are two population in the histogram also. All histograms. And of course in the reticle. So this is a case of bimodal RBC population because of the treatment. There are possibilities, similar kind of the graphs and similar part of the findings can be seen in many situations like blood transfusion, types of bimodal RBCs. Now this is another slide of recovery from iron deficiency and bimodal peak. You can see a peak here, and this is widened and this is going outside the normocytic zone and going into the macrocytic. Now what is the possibility? In contrast to the earlier figure of the recovery, where the recovery was normocytic, here the recovery is showing some macrocytosis. Now This peak is almost at 117. If you draw the line from this to here, this will fall at somewhere at the 117 MCV. This macrocytic response indicates an unmasking of underlying macrocytic disorder. Probably the patient has underlying complete nutritional, predominantly iron deficiency treated, and this is unmasked and surfaced up macrocytic anemia. Use of histogram allows this analysis, even though, now most important, the MCV is 86.8. Now it says that it is a normocytic picture of the particular blood sample, but it is because of the averaging of these two macrocytic cell population and microcytic cell population. If those clinicians who only depend on the MCV or the numerical figures, they probably will not be helped and they will think that the anemia is normocytic, whereas the anemia is having microcytosis and macrocytosis both. Better realized here in this picture, you can see MCV is 87, but RDW is very high, 26.2, and see the population which is going in the macro area. Normo area already there, microcytic cells are there, and it is going into the macro area. Videos. I think, am I visible?
Yes, sir, absolutely clear.
Okay, shall I continue?
Yes, sir, please.
So,
really enjoying
this is a recovery from iron deficiency anemia with a bimodal peak and then another peak coming in the macrocytic zone. Moving again, a very interesting one. Now, again, if you just remember that slide of the advanced iron deficiency anemia, the histogram was almost same, shifting to the left in the iron deficiency. But here we don't find such type of cells. Again, RBC count is slightly higher, hemoglobin is good, hematocrit is good, MCV is low with a normal RDW. Normal RDW. The width is almost same that of a normal graph. Now, MCV is reduced, RDW is normal. Typical of non-anemic heterozygous thalassemia. I'll say non-anemic. There should not be concomitant anemia. If we see here, very interesting, same findings, MCV 70, RDW normal, two graphs, RBC is high. Beautiful finding. This is a coma-shaped cytogram, micro and hypo. Look at it, micro is more, hypo is less, contrast to IDA, iron deficiency. And the typical shape of this gram, what is called coma-shaped cytogram, are also called police cytograms. Moving to heterozygous thal, of course, here RDW is also increased because there are a lot of variation, a lot of anisocytosis in the RBCs is there in the thalassemia. Rest is microcytic, maybe possibility, RDW is there. Again, moving to the next slide. Here, if you go through these parameters, hemoglobin is 12.7, very near to normal, but RDW is high. If you see the graph, slightly shifted to right. So there is some population of the cells which is macrocytic, and it is not, MCV is not entered into the macrocytic area, more than 100 it is not there, it is very much within the normal limit. Normal MCV, RDW high, graph shifted here, it is just like iron deficiency, it's an early megaloblastic anemia. Move here, if you see the smear, typical P polys and hypersegmented polymorph indicates something to you, bigger RBCs, macrocytic RBCs. The graph is totally shifted on the right side. The RBC and hemoglobin is low, there is anemia, and MCV is 110.7 high, and RDW is very high, 18.20. This is a full-fledged macrocytic advanced megaloblastic anemia, where all the parameters are going in the favor of the diagnosis. We better visualize a situation. If the cytogram of early C, there are few cells in the macro zone, but many cells and majority cells are still here, but few cells have moved to macro zone, and this indicates the early megaloblastic anemia. Just like the histogram is slightly moved to the right, just like the RDW is slightly increased. Come to the advanced, here you can see the majority of cells are falling in the macro area. And this is a full-fledged advanced megaloblastic anemia. If I show you the actual slide, you can see here the cytogram without even arrow you can make out has moved to the macro area. If I just say what has happened, N.S.C.B is 120. Cytogram I have already shown is the macro area. Macro percentage is 52. RBC histogram has moved to right side. Macro are 3 plus. Here it is visible the macrocytes. This is the macrocytosis in the true report. Moving to the next, recovery from the megaloblastic anemia. Just look at this. This is not a completely normal bell-shaped curve here. This is on the macrocytic area, and there is a curve which has a notch in the normocytic area. This is a normocytic recovery of the megaloblastic anemia, and RDW is quite high. And here in second graph, if you see, there is a clear bimodal graph. A graph is in the microcytic area. Again, the possibility is probably the iron deficiency, which is concomitant with the megaloblastic anemia, has surfaced up, and we can visualize it that it was a dimorphic type of anemia. And because of the width of this, RDW is very high, 21.5. Better visualize here the two graphs in the microcytic, in the macrocytic, and this megaloblastic anemia. Here it is recovering well. Here also it is recovering, but still some cells are there in the macrocytic area. Coming what we discussed earlier, the red cell fragmentation. Now this is very important, these 2 slides, 3 slides you must see. We have seen all this list of possibilities which causes fragmentation. We do see fragmented RBCs or cystocytes under the microscope on the peripheral smear, but we can't report it consistently, and there is imprecision and there is a subjective error. Here, all these reasons we have already enumerated, so I will not go back. What we see in histogram, this notch on the left side at the beginning of the graph, this notch here, or this notch here, or this notch here, see, this is the pathognomic, no other possibility. There are RBC fragmentations here. And how important it is, in particularly the cases where you are diagnosing or suspecting microangiopathies, how much helpful this simple graph is there. So this is showing the importance of the histogram. These are the cystocytes you can see here. Again here, these notches. And because of this, because of raised RDW, naturally this is wide, and because some cells are there in the fragmented, they are smaller cells in the microzone, so they are visualized in this cytogram very much here. You can very much make out what is the difference. Again, this is a fragmentation of the megaloblastic anemia. Coming to the anemia of chronic infection, look here, anemia is there, but RDW is normal. The graph is absolutely as a normal graph. Most of the anemias of chronic infection are normocytic, normochromic. 20 to 25% cases you may see microcytic hypochromic, and the reasons for the anemia of chronic infection may be suppression of the marrow or maybe other causes, but this situation is we see almost a normal histogram. The same situation of normal histogram or every other parameter normal, but for the anemia parameters and the cytogram within this. Similar picture is also seen in acute blood loss or hypothyroidism, or those situations of erythropoietin where normocytic, normochromic RBCs are produced, but the production is less at the marrow level and they are normocytic, normochromic. The same picture of histogram and cytogram is visualized there. Another picture, hemolytic anemia. Now here there is a macrocytosis. Here there is RDW high with the N.S.C.B high, and there is definitely all parameters of anemia and hemoglobin, they are low. We can better visualize here and see there is a macrocytosis, there is a macrocytosis, there is a RDW is quite high in immunity. This is a case report of where you can visualize. Now naturally in a hemolytic anemia you expect other than everything, presence of normoblasts. I told you when we were discussing normoblasts that I'll be showing you in one of the slides. Now this is the slide. This is a cytogram. This is a cytogram and this is a basocytogram. So this is a signature zone for the normoblast here. It is there, it is present. And this is the tail of this PMN. Here is a zone, there's a dipping here. Normoblast is here. And macrocytosis is associated, so cytogram is going here. So we have NRBCs present there, which is shown here, and MCB is high, so macrocytosis is there. Macrocytes are 3+, and now we are coming to the recovery from immune hemolytic anemia. This is original immune hemolytic anemia we discussed. This is after few months, and this is on the few days, and this is after the recovery. As the recovery from the MCV decreases and RDW reduces, and the graph comes closer to the normal, like what you see in 1, 2, 3. 1, 2, 3. Recovery is from this macrocytosis coming to normal and almost come to normal. Sickle cell anemia, again naturally there will be anisocytosis, so RDW is high, and this may shift, this may not shift. In fact, this particular graph, the numerical values do not go with this, but there is some kind of a RDW change, definite change, because there is a poikilocytosis and anisocytosis here, and graph comes like this. And if you see the cytogram, there is a hyperchromia also in some of the cells, smaller cells which are fully loaded with the hemoglobin and fully hemoglobinized. That's why some of the cells are here in this temperament. Some macrocytes are there, they are in this temperament. Most of the cells fall in the center. Now this aplastic anemia, another type of anemia. This is a biopsy, biopsy, which is naturally deserted. We can make out RBC is low, hemoglobin is low, hematocrit low, MCV is high, and RDW is normal, because this is a hyperproliferative disorder, a disorder of the production at the level of marrow. So RDW is not changed. There is no heterogeneity of the cells. Better visualize here, and you can see some macrocytes here. You can see the shifting to this point, but the RDW is absolutely normal. That was an untransfused aplastic anemia. On transfusion, this kind of a graph comes, and you know the graph, what is there? There is a notch, and this is going into the macrocytic area, which is true cells of the patient, and there are cells here which are the normocytic. This is a transfused blood. Better visualize here. Two populations. This is a recovery from total transfusion dependency to less dependency, to still less dependency, and to patient's own cells of neocytes and macrocytes, no transfusion. This is the recovery which can be seen in those cells. I'm moving to the another anemia because time is short. I think I've exceeded time. There are very few slides more. Please permit me to complete. This is a sideroblastic anemia. I'll go fast. In this, we know that there are dimorphic anemia which has microcytes and macrocytes. RDW is quite high. MCV is almost upper limit of normal because of the averaging of microcytes and macrocytes. Better visualize here, and here you can see there are some cells in macrocytic zone and microcytic zone. This is myelofibrosis. Again, the similar picture in the histogram. RDW is high. MCV is at 87, absolutely normal, whereas this is not truly a normocytic anemia. There are microcytes and macrocytes. You can better visualize, and you can see the cells in this zone and this zone, though the majority of cells are here, and RDW is high with the normal MCV. This is a true dimorphic anemia, maybe because of the treatment or maybe because of the combined nutritional deficiency. Microcytes are there, macrocytes are there, and the graph is extending from this area to this area. RDW is very high. Moving to the very few slides left now. Here, I told you right in the beginning that I'll tell you the story. With this, I'll tell you the story. Way back 2002, 11th of November, I was sitting in my lab. Evening time, my lab was in the hospital, and I had blood bank also. I had one demand for the AB positive group. My blood bank had 4 bags of AB positive. My technician said, "Sir, there is a problem. It is not going well." And I saw the microscope. There were agglutinations on both sides, A and B. So the group was AB, and there were agglutination on the cross match also. So I was worried. My consultant asked me to serve the blood. He said it is AB positive, universal recipient. Don't worry, nothing will happen. I said I'll. I don't know what happened, and I had CBC of the patient in my hand. And when I saw the CBC, I was shocked, because that time I was not aware of the histograms. I was really not knowing much about the graphs. I was not knowing anything about much about the RDW and other things. But basic parameters I was seeing, and they were not going well. RBC was not matching with the hemoglobin. RBC count was low compared to the hemoglobin, and which was not expected. And MCV was quite high, and MCFC was quite high, unusual. On SPA there was no spherocytosis. And suddenly I saw the histogram. I was not bit of, but I saw there's an additional bump. And then I saw other histograms on my table. They had no such bump, and they were Belgian. I said, this is something else. I immediately got a sample of the blood and put a drop of the blood and saw under microscope without adding any NTA or NTB or anything. Patient blood only. And there was already agglutination in that blood. So I thought this AB group is coming because there is already agglutination. I just kept the sample in the incubator at 37 degrees for some time. Again I brought it. Again I did the group, and the group was O positive. Oh my God, I was saved. If I would have given AB positive, you can understand what could have happened. And then I again ran it in my 3-part differential, and everything was normal and proportionate. Now, my dear friends, 2002 November was the beginning of my interest into the CBC. I started collecting CBCs. Normally, I report about 100-150 CBCs every day. So, in my lab, not only I report, but I give it, I'll say. And I started collecting the abnormal graphs and hemorrhages. That was the beginning of ABC of CBC book. It took about 10 years time after that. The book was published in 2011. And now after 10 years, of course, I'm coming with the second volume of that. This is not the platform to discuss that. I'm just telling you how I started. In these 10 years, I started collecting the things and making the book 30 pages, 40 pages, 50 pages. And ultimately, when I was satisfied, the book was 175 pages for publication. So this was the beginning. I wanted to share this story with this slide. And this is nothing but the agglutination. This you can see doublets, triplets, and quadruplets here. And because of them, the RBC count goes down. But naturally, they are hemoglobinized. So hemoglobin remains normal and unchanged. And because of this, MCSC, because of the low RBC count, goes very high. And this is atypical. And here, this bump is coming in the 150 to 230, 200 area is because of these cells. Normally, no macrocytosis goes beyond 125. So this is not true macrocytosis. So this kind of a thing I have seen here. You can better visualize here, and you can see in a cytogram a population of cells which is nothing but those agglutinated cells in the macro area, and this is the bump coming here. MCV is high, RDW is definitely very high. Now, with this kind of picture, because of the variation, you can understand RBC have played the role. I'm telling you one more interesting thing. Look at the rare RBC histogram. We are not discussing WBC, but I'm just telling you, normal WBCs are statistically insignificant to cause any change. RBCs are 5.5 million, WBCs are around 10,000. But I told you in the earlier also, leukocyte count, if significantly elevated from 2 lakhs to like see, we come across this type of histogram of RBC, where again the bump is on the same area. The changes are not here like that what they were there. This here is showing clear cut leukemia. This is because high RBC WBC count is interfering with the RBC histogram, and we are getting the similar, but this is not in because these cells are not hemoglobinized, so this change is not noticed, not much, but yes, there is a change in the N.S.C.B and RDW. You can make out here, just no change in the cytogram here. Again, agglutination, two populations here. Histogram was showing the same thing. Now, one interesting more slide, osmotic change due to hyperglycemia. A diabetic having effect and impact on the CBC report. This is a report where everything is normal, no anemia, nothing. MCV is high and RDW is normal. High MCV with RDW normal, no anemia, unexplainable. So what is this? RBC count and HB are accurate, therefore hematocrit is spuriously high, MCH is correct, MCSC is spuriously low in proportion to the amount of spurious macrocytosis because of all red cells. What has happened? This is a spurious MCV high because water from diluent in a hyperglycemia case with the blood sugar of 600 plus, water from diluent flows into the red cells far more rapidly than glucose comes out of it. So the red cell initially osmotic equilibration is achieved by innate red cell swelling because the diluent goes inside. But why? RDW is not changed. MCV is changed because cells are swollen and they are bigger in size. RDW is not changed because all the cells are swollen. Now if it is treated in sugar, everything comes now. Osmotic change due to hyperglycemia. Same thing here, you can visualize here there are cells in the macrocytic area and when normal it comes here side. These are some fragments which interfere with the counts of these. I will not go into the detail. Thank you dear. I'm sure you must be seeing this skull. But you must be thinking why the academic lecture is ended with this unauspicious type of skull. Let me tell you, friend, this is not the skull. This is a vanity mirror. A beautiful lady is sitting here and she is watching her. I just wanted to emphasize the take-home message for today's lecture. Eyes can see those things which brain knows. Probably a very little change I might have brought with this lecture to some of the students. Now their view of looking into the report of RBC from tomorrow will change, and if it changes, I'll be more than happy. Thank you very much. God bless you.
Thank you so much, sir.
Thank you. Thank you, sir. Thank you.
This is just one of my guru, Dr. M.B. Agrawal, has written a well-executed CBC followed by its proper interpretation has its worth in gold, and a shrewd clinician can make tremendous use of this simple and cheap test for diagnosing hematological and even non-hematological disorders. I salute my teacher, and these are the books you have seen this. And this is on way maybe after 2 months, second edition. Thank you very much.
Thank you. Wonderful lecture, sir. What passion. And a real eye-opener for everybody, I bet. And the best part of this platform is that we have these lectures recorded for convenient viewing subsequently. So we'll be editing the lecture and uploading it on the YouTube so that others can also view, those who have not attended the live show. Dr. Hema Sinha, she says, good evening, sir. She has a small question. Can I put that to you, sir?
Yes, but I would like, because if I go for the second lecture, which is still a similar kind of a lecture is left.
Yes, sir. We are waiting for the WBC and the platelet.
And after that, it will be probably I'll be covering so many things. But still, if I can answer something, please.
Yes. Her question is, if we diagnose microcytic hyperchromic anemia with peripheral smear only, using Mentzer's index, we diagnose the iron versus thal, then why do we need histogram?
Yes, we do diagnose, but you will not, pardon me, you will not deny for the subjective variations and non-consistency in the manual methods. One. Secondly, if you go with the cell counter and go with the numerical values only of MCV and MCH, fine, and RDW also, there is no harm. But is there any harm if you are going with the histogram and if you are going with the cytograms, which tell you much more than simple microcytic hypochromic? There are many other formulas, as I said, MH ratio and other things, which also differentiates between the thal minor and RDA. But still, we are not really very sure about everything that it is. Yes, they are the guidelines. I don't deny the existing methodologies which are there. I don't deny their existence or their integrity. But definitely, if something more with the artificial intelligence is created and encrypted, those informations we are able to just understand. I doubt if there is any harm in that. That is the additional support to our diagnosis.
Absolutely right. Absolutely right. And the things which you have shown us, which can be picked up on the histogram, is amazing. I mean, it's an eye opener for me, and I think for all of us who have been attending, and all of us who will be listening to it further and above it. So we realize the importance of histogram and how at times the numerical values can be really deceptive. Wonderful, wonderful lecture, sir. Excellent. Thanks.
So kind of you, sir. So kind of. I'm
We will definitely request you for the rest of it, maybe sometime later. We'll discuss that.
Yes.
And we have having some comments. Dr. Hema Sinha says, thank you, sir, attending your lecture, understanding the value of histogram now. Absolutely true. It's understanding the histogram value. Really, we are all understanding what all we can diagnose from the histogram, and especially the hyperglycemia was really mind blowing. It is really mind blowing, sir. I mean, I have never heard of this also. Wonderful. Let me see if there are any comments on YouTube. Yes, there are many. Dr. Nilesh Kapadia says, need more of you. So Dr. Nilesh Kapadia says he wants you to come back again and again and teach us more and more. Dr. D. Singh says, well done, a passionate presentation. Dr. A. Mitra, a true eye-opener and a real treat. Dr. Nilesh Kapadia says, sir, we want you to speak more on the 5-part cell counter. So these are some of the comments on YouTube, and they are pouring in. Please understand that there's a 1-minute delay between the Google Meet activity and YouTube activity. So as and when the comments are coming. Dr. Rajesh Kumar Kevat, excellent, nice topic, very well presented, excellent eye-opener. Right, sir, wonderful, excellent presentation. I wish we could continue more, but I think we will keep it for the second session.
I think I have taken a lot of time. I thank all those who have been with me for more than 1.5 hours, almost 1.5 hours. I really thank you. Thank your patience and cooperation. God bless, and it is you because of which I could present. Thank you. So kind of.
Thank you, sir. Thank you. Thank you so much.
The pleasure is all ours, sir. It's an honor to have you on this platform. Time is not a factor. It is your time which is more important. And a person of your stature coming and speaking and teaching us so much is a wonderful job, sir. We all really appreciate your passion at this age. Wonderful. God bless you, sir. Thank you so much. We will definitely have you soon for the next session.
So nice of you. God bless you, Nadeem. And thank you very much for your wonderful comparing and wonderful taking the lecture to this point, really. And I salute you for what all you are doing for the students and postgraduates. Thank you.
Thank you, sir. It means a lot to us.
And thanks again, once again to Dr. Anita Telia. It was she who brought me here, and I really thank her for this.
Yes, all credit to Dr. Anita Telan for having you here. But we will surely have you soon for the next part of it. And then the tremendous question answer session will definitely be there. There must be a lot of queries in everybody's mind. So till then, sir, Good night. Thank you so much. God bless everybody. Bye-bye. Take care, sir.